Welcome to the weekly webinars organized by the Saudi Society of Blood and Marrow Transplantation. Today we will have an excellent session with different format where three consultants in the hematology will present different cases about acute myeloid leukemia. And we will have a discussion about these cases, and these cases will be interesting for the audience. So it is a great pleasure for me to have two speakers, and I will be presenting the third case. My name is Mohsen Al-Zahrani. I'm hematology and stem cell transplant consultant from Ministry of National Guard Health Affairs, Riyadh. Also, we have Dr. Marwan Shaheen. He's consultant of hematology and stem cell transplant in King Faisal Specialist Hospital, Riyadh. Dr. Marwan Shaheen graduated with MBBS from King Saud University, Riyadh, and finished his residency from King Faisal Specialist and Research Center. He then carried on to complete his fellowship on stem cell transplantation from King Faisal Specialist Hospital, as well as a fellowship in the leukemia and bone marrow transplantation from Princess Margaret Hospital, University of Toronto, Canada. Currently, Dr. Shaheen is working as a consultant, adult hematology and hematopoietic stem cell transplant section, oncology department, King Faisal Specialist Hospital and Research Center, and has been active in various research and peer-reviewed journals. Dr. Marwan has special interest in myeloid malignancies and transplant for myeloid malignancies. Also, it's a great pleasure for me to introduce Dr. Salim Dada. Dr. Salim graduated with bachelor degree in medicine from University of Science and Technology, Yemen, and completed his residency in internal medicine from King Fahd Hospital, Al Baha, Saudi Arabia. He is currently a consultant adult hematology and bone marrow transplant in Princess Noura Oncology Center, King Abdulaziz Medical City, Jeddah. In addition, Dr. Dada has been active in chemotherapy-related protocols, writing, as well as in medical residency and hematology fellowship teaching activities. This meeting, next slide. This meeting tonight is sponsored by Astellas. We would like to thank Astellas for sponsoring this activity. So we will start with the first case, which will be presented by Dr. Salim Dada. Dr. Salim, you can start.
Assalamu alaikum, and thank you, Dr. Mohsen, for the introduction. And I want to thank the SSBMT and Astellas for organizing this meeting. So I'm going to present a case, a real case that we have treated in our center with difficult to treat AML. So I'll start directly with the case. I have a 27-year-old lady who presented to us in September 2019, 3 days post-emergency cesarean section, delivering her 4th child. Prior to that, she was diagnosed in a type with AML during her 3rd trimester of pregnancy. Her initial white cell count was 40,000. Bone marrow confirmed AML with karyotype 46XX with monosomy 15 and unknown marker. Baseline molecular profile showed that she had NPM1, NRAS, WT1, and IDH1. So NPM1 mutated AML. She had a complicated intra-abdominal infection post C-section with ESBL E. coli requiring multiple CT-guided drainage and prolonged courses of IV antibiotics. She received induction with 7+3 with IDA Robeson 12 milligram per meter square on October 8, 2019, and achieved morphologic remission. This was followed by 1 cycle of IDAC, 1.5 gram per meter square, and in November 2019. And she had a repeat bone marrow assessment post the first IDAC, and that showed that she's in molecular CR with negative NPM1 by NGS. She had an HLA typing, which showed that she had a full match sibling sister. What would be your best what would be your post-remission therapy for this patient? Would you recommend chemo, auto stem cell transplant, or allogeneic stem cell transplant? So this is from a paper from the New England Journal of Medicine a few years ago on patient with NPM1 mutated AML from the UK MRC cohort. They showed that patients who achieved MRD negativity post 2 cycles of chemotherapy, they have a 34% cumulative risk of relapse, as compared to 86% risk of relapse in patients who are MRD positive post 2 cycles of chemotherapy. We are speaking here about NPM1 mutation specifically. So the decision usually to take a patient to transplant in CR1, usually a cut point of 50% or more risk of relapse would favor to do allogeneic stem cell transplant in CR1. Here, probably with achieving MRD negativity molecularly after cycle 2, the risk of relapse is less than 50%, and probably you have a chance to cure this patient with chemo alone. So subsequently, she received 3 cycles of IDA consolidation. However, unfortunately, bone marrow post the 4th IDAC on April 8, 2020 showed relapse disease with 61% blasts in the bone marrow. Karyotype showed the same karyotype with 46XX deletion 15, which was the same karyotype as the original diagnosis. We repeated her molecular profile on relapse, which showed that she acquired FLT3 ITD, which was not present on the initial diagnosis, together with U2AF1. She maintained her NPM1, NRAS, WT1, and IDH1 was lost. And this graph shows you that she had a 10% mutational burden FLT3 ITD on relapse. So acquiring FLT3 ITD on relapse is not unheard of. It's actually could be a common scenario, especially in NPM1 mutated AML. In this paper, clonal evolution in relapsed NPM1 mutated acute myeloid leukemia showed around 41% of patients acquired FLT3 ITD on relapse. So almost half of the patients acquired FLT3 ITD on relapse. So which salvage would you use for this patient? Would you use FLAG-IDA? Would you use MEC? Would you use CLAG? Or would you use VP-Cy? In this patient, we actually give 2 cycles of chemotherapy. She subsequently received 2 rounds of salvage chemotherapy. She received FLAG-IDA on April 2020 and cyclophosphamide etoposide on May 2020. Unfortunately, her disease grew through both chemotherapy. And afterwards, she received 2 cycles of subcut RC just to control hair counts together with hydroxyurea and sorafenib. High-dose cyclophosphamide and etoposide, we have been using this protocol for years now in treating refractory leukemias, refractory ALL and AML. We usually use it as a second salvage. This paper from Blood more than 30 years ago showing the original protocol. A newer report on this protocol was from BC, British Columbia. They reported the outcome of 169 patients diagnosed with relapsed refractory AML treated with VV-Cy at their center. The etoposide dose was 2.4 grams per meter square, giving us continuous infusion over 34 hours, followed by cyclophosphamide 2 grams per meter square for 3 days. So a total dose of cyclophosphamide 6 grams per meter square. So intensive chemo. The CR rate was 45% in their cohort with a 5-year overall survival of 20%. Patients with FLT3 ITD have a lower CR rate and worse overall survival as compared to those without. And patients with adverse risk cytogenetic had a trend to a lower CR rate, and they have significantly worse overall survival. And this is the overall survival in that cohort, 20% at 5 years. So for our patient, back to our patient, we have requested compassionate gilteritinib to her, and And it arrived in August, so 4 months after her relapse. She relapsed in April, and we started gilteritinib in August 18, 2020. We started with a typical dose of 120 milligram per day, which she tolerated very well. Day 28, cycle 1 gilteritinib showed partial remission with 20% plus in the bone marrow from a baseline 90%. So according to the Admiral trial, the dose was increased to 200 milligram per day, so 5 tablets per day, sorry. And at the end of the second cycle of gilteritinib, her bone marrow showed 5% plus by morphology, so almost CR. Gilteritinib have been compared to chemotherapy in the famous Admiral trial published in the New England Journal of Medicine recently. It was 2-to-1 randomization of gilteritinib versus chemotherapy in relapsed refractory AML. Median age was 62. Most patients had intermediate risk cytogenetics. Around 20% in each arm had prior allogeneic stem cell transplant. And around 1/3 had primary refractory disease. The primary mutation was ITD in 90% of patients. So gilteritinib did better than chemotherapy with better overall survival with a hazard ratio of 0.64. Response rate were higher, complete response and complete response with partial hematologic recovery, 34% versus 15%. Composite complete remission, including all remission even without count recovery, were 54% versus 21% in the chemotherapy arm. The important to note here that the time to complete remission was 2.3 months in the gilteritinib arm versus 1.3 in the salvage chemotherapy arm. So probably you need an addition, at least 2 cycles before you can achieve remission. So back to our patient, she subsequently underwent matched sibling allogeneic stem cell transplant with myeloablative BUSI. Transplant complication, neutropenic fever with lobar pneumonia, treated with IV antibiotics and amphotericin, and grade 4 oral mucositis. Post-transplant, we started gilteritinib 40 milligram at day 49, and a week later was increased to 80 milligram. CSA TAVR started from day 60 plus. Unfortunately, day 70 plus, her peripheral SME showed circulating blast. So we took her off immunosuppressive, and we increased the gilteritinib dose to 120 milligram and plan to give her azacitidine. Day 80 plus post allogeneic stem cell transplants, he was admitted with fever and cough, was found to be COVID positive, rapidly deteriorated with hypoxia requiring intubation and mechanical ventilation, and unfortunately she died a week after. By here I conclude. Thank you very much.
Thank you, Dr. Salim. Very interesting and difficult case and refractory. Maybe me and Dr. Marwan will ask 1 or 2 questions, then we'll proceed with Dr. Marwan case. At the end of the 3 cases, we'll open the Q&A session. So just 1 question, Dr. Salim, why intermediate dose RC? Why not high dose RC?
Studies have shown that that actually there is no difference between intermediate dose RC and high dose RC. So what we use is something between 1.5 and 2, and studies have shown that there is no difference. Even in the Ellen guidelines, the most recent one, they recommended intermediate dose rather than high dose RC.
Okay. Any significance of deletion 15?
No, especially with NPM1 mutated AML, it wouldn't change the risk category.
Okay. Do you have any question, Dr. Marwan?
No, I don't have question.
So we may have more questions at the end from the Q&A session. Thank you, Dr. Salim. Now we'll go to the second case presented by Dr. Marwan.
السلام عليكم. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير. Thank you for inviting me to share this case, and thank you for the SSBMT and Dr. Mohsen for his nice introduction. You can see my slides, صحيح?
Yes.
This is a disclaimer. This meeting arranged by Astilis. I will give actually more history, more detailed history, I thought, because maybe we have in the audience residents or fellow, but I'll try to be quick, and I promise that this patient's still alive as of yesterday. يعني فإن شاء الله يا رب he will pass it, he will cure إن شاء الله. A 54 years old male who was referred from Asir, known to have diabetes mellitus and dyslipidemia. He underwent a tooth extraction 1 month ago, which was not an easy tooth extraction, complicated by abscess collection. So most likely by that time he was having the acute myeloid leukemia, but undiagnosed. 1 week after the extraction, which is 3 weeks before he presented to us, he started to have fatigue, epigastric pain, nausea, vomiting. He was vomiting 3 to 4 times with a small amount, which is the gastric content. So I thought maybe septicemia can cause this. Later, he developed also a dry cough with shortness of breath and subjective fever. So the all over period, he also developed a weight loss of 5 kilograms in 1 month, and it's unintentional. Also, there was a significant night sweat in history. Further history revealed 1 episode of epistaxis, so most likely his platelet was low even at that time. So in our emergency room, he was febrile, slightly hypotensive on the baseline and tachycardic. He was still alert and oriented with some right lower zone crackles on examination. There was no lymphadenopathy. Otherwise, cardiovascular examination was unremarkable. Also, there was no abdominal tenderness, and there was no skin lesion or rash, and his neurological exam was grossly unremarkable. He presented to Asir before us with WBC of 80,000. When he reached King Faisal 2-3 days later, it was 87,000, hemoglobin 86, platelet 51, so he was holding, and there was no picture of the IC when he presented, but his troponin was increased 254. They repeated and still increased. They work him out later, but ECG and echo was unremarkable. There is a CRP elevated, and his chest X-ray shows increased interstitial marking. Abdominal X-ray was unremarkable, and in emergency room, his peripheral blood smear revealed 80% blast with our roads also seen in the peripheral blood. So cardiology quickly came to assess him in emergency. ECG, no ischemia, echo unremarkable. Also, cardiology asked for BE study as one of the differential of high troponin. It was done. We started him immediately on ATRA before we rolled out APL with hydroxyurea, with hydration, bone marrow biopsy done, and confirmed the diagnosis of acute myeloid leukemia. His fish was all negative or normal, and karyotype revealed normal karyotype. And so patient was started on 3+7 on 13 of March 2021. His molecular study came around 5 days later, showed FLT3 positive, NPM1 positive, SIPA negative. This is the main molecular. And recently in King Faisal Riyadh, we sent myeloid NGS for all patients, which is like we missed this for years. And I'm really glad that we start to do this. So The myeloid is automatically myeloid NGS, where they examine these mutations in our panel, which is, I think, the same as Germany and USA. It came positive for NPM1, as I mentioned before, and WT1 and FLT3. And the way how they report in the NGS, I like it because they put the trial number. And also they give you the trial names later, like this. And they give you relevant therapies. And so this is just to show you how they reported. Patient on day 3 of chemo, he started to have upper eyelid. This is not the patient. This is a picture from Google, but it was the nearest to explain the patient situation. He was having upper eyelid infection or inflammation, and a day later, only a few hours later, his eye was all closed. So we called the ophthalmology colleague, where she come at the bedside. She said that it was severe pain and touch. There is limitation of the ocular motility, severe upper eyelid swelling, and right eye with chemosis with right side facial swelling. She gave the impression of cellulitis, but she was very concerned, and they came quickly and they asked for immediate image and ENT to come immediately. I was glad that they come very quickly, and then I figured out why they are very concerned, because 1 week before this time, they have a patient in liver transplant floor who developed a mucormycosis, and they did for him removal of the eye. So they were very, of course, shocked with that patient, and that's why they came immediately when we called, and ENT was there right away to take biopsy. The MRI first, let me give you that. There was an impression that it's possible to be invasive fungal infection, and there was also mild paranasal sinus mucosal disease. So patient immediately started on amphotericin, posaconazole, and ID was on board. ENT came to do immediate biopsy, and they did even the frozen section to rule out fungal the same day. So half an hour later, they give us that there is no invasive fungal, but we waited for the final pathology, which come later as AML. So whatever was in the orbit eye and in the nasal, it was AML infiltration from the disease, and we resume chemo and we adjust antibiotic accordingly. So as he is a FLT3, we in King Faisal, we not have midostaurin or gliterinib, and we are using sorafenib so far. We started 200 milligram BID, and we consult our expert in FLT3, Dr. Ahmed Uthman, who told us that it's better to use the sorafenib from day 8 to 22, although many study can use sorafenib from the beginning or whenever you have the FLT3 positivity. So we started on day 3 sorafenib 200 BID. Patient developed chest, abdomen, and back multiple erythematous macule, and this is not uncommon with sorafenib. And the problem that it's very difficult to say it's sorafenib induced or no. Usually we call dermatology, they do biopsy say drug eruption, and then we try to hold the sorafenib or reduce the dose. This is what happened because it's reached grade 3 to 4 skin lesions, so we reduces the dose to once daily, and we give methylprednisone as per the recommendation of dermatology. And after the methylprednisone, the rash reduced, and he showed also the area which was C. diff positive, so we thought maybe it's not really the sorafenib. I have a similar case who is now transplanted 2-3 years ago, And we didn't give her any sorafenib after the severe skin rash. She was labeled as sorafenib, allergic to sorafenib. And unfortunately, we didn't give her any maintenance. And good that she didn't relapse, and she didn't require really the anti-FLT3. In this case, most likely still, I'm not sure, but most likely it was sorafenib induced. He tolerated the sorafenib later, which happened in sorafenib. So even the hand-foot syndrome would happen with sorafenib. By the way, with our colleague in hepatocellular carcinoma, they consider the hepatocellular, the sorafenib-induced foot hand syndrome, that those patients have more outcome from sorafenib because the absorption is better, and those usually responded according to their clinical trials. So in those patients, even we only hold sorafenib, reduce the dose, and then resume again. So this patient, after we label him as an extramedullary AML, and he completed 15 days of sorafenib, his day 28 bone marrow biopsy was showed no leukemia, and molecular-wise, his FLT3 and NPM1 both came negative. But unfortunately, his CNS study from lumbar puncture was positive with 6% blast. So we started him on high-dose methotrexate with cytarabine IT intrathecal therapy, and high-dose RSC as consolidation. And he is prepared after that when his CNS is clear for allogeneic stem cell transplant. The challenge in this case was the late presentation, as usual. We face this problem more often with APL patient, as they come usually after receiving chemotherapies, very sick, or later presented with DIC picture. But our colleague with personal communication, always when there is a suspicion of APL, we call each other and we bring the patient right away from Qasim, from Hayel, from Asir. We have always easy referral in those cases, but they present late. So I finish from this case, and thank you for listening. And I'm willing to receive any question now, or if Dr. Mohsen wanted at the end, not mind.
Thank you, Dr. Marwan. Very interesting case, and hopefully he will do well with your treatment. Just one question. When did you test for the LB? Is it when he had the eye involvement, or after?
No, actually, because the platelet was very low from the chemo, and our guideline is to do LP only if platelet more than at least 40, and we tested only with the recovery on day 28, and it was positive, unfortunately. So we're not sure. Maybe it was before even positive, the CNS. His eye improved dramatically with the antibiotic and continuing chemotherapy. So only 2 days later, he opened his eye, and ophthalmology and ENT were examining him and showed marked improvement, which was a good sign. Yani sometimes, if this is invasive fungal, it will need a surgery, and he was lucky that there is no invasive fungal. And
the MRI brain did not show any brain lesions or leptomeningeal enhancement? Okay. It's a tough case. Hopefully he will, so you'll take him for transplant.
I hope, yeah. We hope so. So if he clear, yes, if he clear his CNS, hopefully.
Okay, good. We'll have more questions later on, and I will ask, you have the question, Salim?
Yes, please. So Dr. Marwan, do you do the allelic FLT3 ITD allelic ratio?
We not have, unfortunately. Okay. So even, we not have it even as send out, which is bad, really, because our contract with my clinic, and they not have the allele ratio. So we are not doing this.
So let's say, for example, that his allelic ratio is low and he achieved the NPM1 negativity as in this patient. So would you still take him for transplant?
So the baseline allele ratio is maybe more important to decide about this. And
Yeah, I know.
now with this extramedullary, we still will take him for transplant with this CNS positive extramedullary disease. Yes.
Okay.
Okay, so I will present my case. I'll ask the audience if you have any question, please post it in the Q&A site. So we'll ask your questions after my case. Okay, so I will share my case now. Okay, so this patient is different than the previous two cases. He's old patient, 78 years old male, known case of type 2 diabetes on metformin and hyperlipidemia. He presented in August 2018 to ER with history of fatigue associated with weight loss for 4 months before his presentation and gum bleeding. There was no fever. An examination, elderly, frail patient. His ECOG performance before his presentation, almost zero, and he is taking care of himself, fully independent, active, but because of the sickness, he became like sick. He has mild pallor, no palpable lymphadenopathy, no palpable hepatosplenomegaly. This is initial blood investigations. He has very high WBC, 80,000, mild anemia, mild thrombocytopenia, 85% blast, neutrophil normal, mild coagulopathy, and mildly low fibrinogen. Mild renal impairment with high blood sugar, very high LDH, high uric acid. So he has some features of early TLS and features of uncontrolled blood sugar with A1C 7.5. He is carrier for hepatitis B, core positive. So we did bone marrow biopsy for him, which showed acute myeloid leukemia not otherwise specified. The morphology is mostly compatible with AML without maturation, M1, AML M1. The flow cytometry showed 80% blasts positive for CD11, CD13, CD117, and HLA-DR. The blasts are negative for CD34, CMBO, monocytic, and B and T lymphocyte marker. In summary, the immunophenotype is consistent with AML. Cytogenetic and molecular, the BML RARA gene mutation was negative by FISH and by molecular test. Cytogenetic showed that he has 46XY with monosomy 9 and deletion of long arm of chromosome 13, which was confirmed also by FISH. By molecular, he has both FLT3 ITD mutation positive and MBM1 mutation positive. Here we don't do the allelic ratio for FLT3 ITD in our hospital. So he's 78-year-old male with, we can consider it minor comorbidities, diabetes and hyperlipidemia, with good performance status before admission. We did echo, he has normal ejection fraction, impaired left ventricular relaxation. He has normal liver and kidney functions. AML, monosomy 9, deletion 13q, MBM1 and FLT3 ITD mutations. So we labeled him as intermediate risk. And if we have the allelic ratio for FLT3 ITD, he can be either in the low risk or intermediate risk. So these are the treatment options that we put when we have him at the time of the diagnosis. Induction chemotherapy 7+3 or 5+2 or HIDAC. Obviously, with his age 78, he is not fit for induction chemotherapy, at least in our hospital. induction chemotherapy followed by allogeneic stem cell transplant. The same thing, he will not be fit for induction chemotherapy and allogeneic transplant. Palliative chemotherapy is an option, but he is more fit than palliative chemotherapy. Best supportive care, hydroxyurea plus transfusions. Also, he is more fit to receive more directed treatment. Azacitidine will be a good option, but we have the chance here that he is FLT3 positive, and we have the chance to add FLT3 inhibitor to azacitidine. Venetoclax and hypomethylating agents. Obviously, Venetoclax at that time, 2018, was not commonly used in or approved for the treatment for AML in this age. FLT3 inhibitors choice, midostaurin, sorafenib, which are the first generation, and the second generation, gilteritinib and quizartinib. The last two, usually they are used and approved for relapsed refractory cases. Midostaurin is approved in conjunction with 7+3. So sorafenib is an option for this patient. If you look to the NCCN guidelines, the most updated one, an adult patient above the age of 60 who are not candidate for intensive remission induction either because of their fitness or because of their age. We have this pathway. So in the lower part, they have FLT3 mutation. The preferred regimen based on the most recent guidelines is Venetoclax based therapy plus azacitidine or decitabine. Another recommendation is low intensity therapy azacitidine plus sorafenib or Venetoclax single agent. The approval for use of sorafenib in this guidelines is based on this study. Sorafenib plus 5 azacitidine in older patients with untreated FLT3 ITD AML. It's phase 2 study, 27 patients from MD Anderson Center. The age is 74 and the age range from 61 to 86. They used monthly azacitidine with the typical dosing 75 milligram per meter square daily for 7 days, plus sorafenib 400 milligram BID. Treatment cycles in this study, the median was 3 cycles, but some patients went up to 35 cycles. The overall response is 78%, and mostly they are CR or CRI, which is very impressive at this age, almost similar to what we get with induction chemotherapy in young patients. Overall survival 8.3 months and 9.2 months in responders. And here is the remission duration curve, and here is the progression-free survival. At the end, most of the patients, they will relapse. And the use of Venetoclax in this guidelines is approved based on this study, which is a phase 3 study, azacitidine plus Venetoclax in previously untreated acute myeloid leukemia, 431 patients with AML unfit for standard induction. Arm 1, they used azacitidine plus Venetoclax, and Arm 2, azacitidine plus placebo. Significant CR and CRI with experimental arm compared to the azacitidine plus placebo, and also statistically significant improvement in the overall survival in azacitidine plus Venetoclax. And if you look to different patients group, most of the patients group responded. FLT3 positive, they have better outcome with the azacitidine and Venetoclax, but they did not cross the line. So based on this study, this is an option for patients with elderly patient with AML, including FLT3 positive. And then the NCCN guideline, they put it as a preferred option over azacitidine plus sorafenib, because the study of azacitidine and sorafenib is phase 2 study. So case discussion, this patient at advanced age preclude him from standard chemotherapy. He also has a highly proliferative AML with FLT3 ITD mutation. He presented with very high white blood cell, 80,000, with feature of TLS and early DIC. which argue for the addition of an FLT3 inhibitor in the absence of clinical trial and lack of mature data using second generation FLT3 inhibitors in newly diagnosed AML. Our preferred choice would be to treat him with a combination of sorafenib and azacitidine. But now there is an ongoing study, I think, with gilteritinib plus chemotherapy treating in frontline FLT3 inhibitors, AML. So this was in August 2018, almost now 2 years and 6 months follow-up. The patient treated with azacitidine first cycle. The result of FLT3 came to be positive after that. So from the second cycle, we added sorafenib. Bone marrow biopsy morphology after 2 cycles showed morphologic and cytogenetic remission. He had monosomy 9 and deletion of long arm of chromosome 13. However, he was still positive for FLT3 ITD and NBM1 after 2 cycles. We carried on with azacitidine and sorafenib every 28 days cycles, azacitidine for 7 days and sorafenib 400 milligram BID. He continued to have more hematologic response and almost normalized his CBC. Repeated bone marrow after 1 year, he was in CR, including negative FLT3 ITD and NPM1 mutation. So the patient completed 18 cycles of azacitidine plus sorafenib until February 2020, when we had the corona epidemic. And at that time, the patient preferred not to come to the hospital to take azacitidine. So we stopped azacitidine after 18 cycles and we continued sorafenib. Patient is still on sorafenib for 200 milligram BID since September 2018 until now, almost 2.5 years. And fortunately, alhamdulillah, he's still in remission. So this is the end of my case. Thank you.
MashaAllah, tabarakallah.
Outstanding.
Yeah, alhamdulillah. Not always, but hopefully he will keep in remission, inshallah.
How he tolerates sorafenib? Did he develop any rashes, any hand-foot syndrome?
No, there was nothing. He tolerated very well. He has a compliance issue. I always instruct him to take 400 BID, but he sometimes go down to 200 BID, so 1 capsule BID. I want to keep him.
They develop diarrhea usually also. They develop bad diarrhea, initially only.
Yeah. Well, I did not see any one of these significant toxicities from sorafenib in his case. Until now, he's on 200 BID and he's tolerating well. And this study, the phase 2 by MD Anderson, they continued until disease relapse. So this is my aim, is to continue, because if he relapsed, I don't think we have other options.
I think your choice was excellent, لأنه إحنا with Venetoclax we have toxicity issues, and you have to give it also for a long time. So I think the choice was excellent. Also for the case of Dr. Salim, they do till the end, they try their best, and then COVID came. We have similar case, when COVID have an immune suppressive patient, it's very bad.
Yeah.
And our patient was in ICU. She was an APL patient who was treated with chemo in outside Riyadh, and she came with COVID, same time. And then she deteriorated very, from APL point of view, her molecular came negative immediately. But COVID, she stayed 3 months on ventilator.
Okay.
But the good news that our ICU, because of this massive fibrosis, they put her no code because she will not be eligible for lung transplant. So with immunosuppressive, post-COVID lung fibrosis improved dramatically on steroid and steroid-sparing agent. And she become off ventilator and now only on 2 liter. And alhamdulillah, at least she named it.
Yes. Okay, so thank you, Dr. Marwan, Dr. Salim. We'll go to the Q&A session. And I will ask all the audience, if you have any question, please post it there. So we have one question. Can any one of the speakers comment on the average number of cycles needed for FLT3 inhibitors to put patients in CR? And I was planning to ask you this question, Dr. Salim. When you used gilteritinib, what was the recommended number of cycles before taking the patient to the transplant to put him in remission?
So according to the trial, the median time to respond or to achieve remission was 2.3 months. So at least 2 cycles.
Okay.
Probably with giving more cycles, you will achieve deeper responses. But unfortunately, the amount we had was enough only for these 2 cycles. So we just accepted the 5% plus and we took her to transplant.
Okay.
But probably giving 3 or 4 cycles prior to transplant and achieving deeper remission could be could have a better result. You know that achieving a deeper response prior to transplant translates into a better survival post-transplant.
Yes, sure. I mean, the gilteritinib is apparently a very good drug, and it is like more selective or specific to the FLT3. But the problem, we use it in very advanced cases with usually multiple relapses, refractory cases. So we don't see this impressive responses so far. Even in, we used it for 2 cases. There was stable responses, but at the end, the patients, both patients relapsed. So if we will have it in the first or second line, that will be maybe a better option to use gilteritinib.
Yes.
Okay, so another question. So Dr. Marwan, this was clearly coloroma in the eyelid. Is there any plan to
not in the eyelid? Yeah, most likely it's the same, but the biopsy was from the nasal inside, like near the orbit. But of course, this is all the same etiology.
Mm-hmm. Any plan? Are you planning to do radiation therapy after transplant?
I think you're right. With the conditioning, we should maybe consider the cranial boost in his case.
Yes.
This is what we do usually.
Yes. So you will do the conditioning will be
with cranial
TBI based with cranial boost. Okay.
Yes.
Another question: is there any thought of your patient with Venetoclax plus Azacitidine plus gilteritinib instead of only Azacitidine plus gilteritinib? Did you use Azacitidine, Dr.
This is for Dr. Salim, yes.
We were planning to start, but unfortunately the patient had the COVID infection. But I agree with the question. It's a great question, actually. I think the triple combination could be better than the double combination. So using a hypomethylating agent plus Venetoclax plus FLT3 inhibitor in the relapse setting. And there were data presented in the last ASH of the synergistic effect between gilteritinib and Venetoclax. And probably the triple combination is better. We don't have the Cytogenetic. I was planning to give her Azacitidine, gilteritinib, and then see how things would go afterwards. But Venetoclax is a good option, actually.
Okay, so a question to me, to Dr. Mohsen. Why did not start Venetoclax in addition to Aza and sorafenib? So the patient was diagnosed in 2018, August. At that time, Venetoclax was available but was not approved in this indication as a front line therapy for AML. So this is why we used only Azacitidine plus sorafenib.
I have a question to Dr. Salim. Do you have NGS now for your AML patients you are doing?
It's actually sent out, yes. And we are doing it for all AML patients since 4 or 5 years now, almost. All our AML patients.
What's the turnout time يعني تقريبا 2-3 weeks ولا more?
لا, 3 to 4 weeks.
3 to 4.
3 to 4 weeks. Sometimes if there is the FLT3 ITD is positive, they give us like a pre-report or in 2 weeks or 3 weeks. But usually it takes 3 to 4 weeks.
بس انت you are doing المولكيولر FLT3 صح in house ولا حتى لا؟
لا لسه. unfortunately
okay.
not made. But
Dr.
we are
Mohsen,
planning.
you have NGS also in Commissioner Guard?
No,
Riyadh?
the same thing. We sent out to patients.
روتيني
Yeah,
لكل المرضى ها؟
yes.
احنا ما
But
كان عندنا واحنا زعلانين يعني تو جديد الحمد لله احنا ما كنا نعرف نرسل السند اوت يا رجل ما كان عندنا
so you'll do it now in house the
الحمد
NGS.
لله الان جديد يا رب الله يتمم علينا يعني تو ما
Okay.
لهم الا يمكن
Great.
شهرين او شيء زي كذا.
This will be
Okay.
perfect. Yes. We do the PCR for FLT3 and MBM1 in house.
ايه احنا
But
كذا بيعطونا ايوه
yeah,
بس الان جي اس ما كنا نسوي الان
yeah.
حتى في الام بي ان الحمد لله نقدر نسوي.
It will be great if you can do the allelic ratio for FLT3 because this will help you in the
وما
stratification.
عندنا تعرف ما عندنا كمان الانفيرجن 16 موليكولر ما عندنا
Yes.
ولا send out حتى ما لقيته send out which is bad really because you know the inversion 16 validated على البريفرال هذا الحلو حق انه you can send it peripheral فما
Yes.
عندنا ولا لقيناه حتى send out.
Okay.
We have question by Dr. Ahmed Al-Askar, but apparently the toxicity is higher with the addition of Venetoclax to Azacitidine and Sorafenib. Has any one of the speakers used this combination? For us, we did not use it. I'm sure there will be more toxicity with neutropenia, especially neutropenia. But we will see if there is any, we'll follow if there is any reference or study supporting this combination, and I'm sure there will be those adjustments.
And we use the same as Mohsen did in one patient, Aza Sorafenib 400 BID. He tolerated that patient. He was doing well. Again, he was elderly. With Venetoclax, the three no. But with Venetoclax, Aza, we face some toxicity. عندنا الشيء new we face it إنه hyperpigmented photosensitivity. They become really dark after 2-3 cycle. I spoke to the company and there was no reported case even in the international, but we have like 3 or 4 cases of this.
Yeah, the main toxicity will be neutropenia of using Venetoclax, but this is expected, and the recommendation from the studies is to continue
Yes,
regardless.
not to hold.
But yes, to cover with antimicrobial.
But now the new studies are only doing 21 days, and I think this will be the future.
Yeah.
21 days, then hold, and after 2-3 cycle, enough to judge. I give some patient more with no benefit, so I think 2 to 3 cycle will be enough for you to judge the response.
Yes.
A question from Dr. Muhammad Al-Asmari: any experience with gemtuzumab ozogomycin?
In FLT3?
In FLT3 or in AML in general, did you use it?
We use it only with the core binding factor.
Yeah.
Dr. Said Othman did our guideline and he included 2 doses. We give only 2 doses, one with the induction and one with the one consolidation only.
And there is growing evidence on the using it and also in NPM1 mutated AML. So some guidelines include the NPM1 mutated AML to use gemtuzumab in the upfront therapy.
والAPL relapse APL, we use it 1 patient only.
In FLT3, I think there is 3 studies with conflicting results. 2 studies support the benefit, but another study did not show any benefit from it. So it's not in the guidelines for FLT3 AML. Is FLT3, the question by Dr. Shahid Ahmed, is FLT3 allelic ratio is important, or FLT3 positive patient should go to allo SCT irrespective of the ratio? For anyone can comment.
According to the NN guidelines, so patient with low allelic ratio, they are intermediate risk, and patient with high allelic ratio, they are high risk. I think if you have FLT3 ITD with wild type NPM1, it's very difficult not to take the patient for transplant. But if you have mutated NPM1 and the patient achieved NPM1 molecular negativity, there is an argument for not transplanting this patient. But if only depending on the allelic ratio, I think it would be difficult not to transplant in CR1, especially if there is a good donor. upfront.
Yes. Yes.
Well, this based on the earlier, like maybe 6 years now, Spanish group study in the earlier. But I agree with Salim. My threshold for transplant would be very low.
Yes. A question by Dr. Ahmed Al-Askar. I have an MDS who sustained prolonged cytopenia. I think maybe he mean from Venetoclax plus Azacitidine as a toxicity. Yes, this is what we usually see. Sometimes they can have very prolonged cytopenia, and you will you interrupt the treatment until they recover. Then you dose reduce the Venetoclax.
Nowadays, we have more cases of unclassifiable MPN/MDS/ Philadelphia negative Philadelphia negative CML. We were not seeing those cases a lot صراحة. Did you have the same in Jeddah and Riyadh? يعني unclassifiable MDS/MPN where you cannot really classify it.
We have these overlaps, yes, yeah. I think in this situation also the NGS would help you. Sometimes we send even WES, whole exome sequencing. That takes me to a question whether, when do you test for germline mutation in your AML patients? For Dr. Mohsen and Dr. Marwan.
So in general, a young patient with AML, especially if there is family history or if there is like MDS or aplastic anemia features, we usually check for germline mutation. Or if the NGS showed a mutation that can be associated with a hereditary germline predisposition to AML, then we will check for the germline mutation in the patient, and if he's for transplant, also we'll check his donors.
Okay.
Same, yani for not for any AML, no, only with MDS clear or features of like hereditary anemias, we suspect breakage, مثلا not clear. We I send it maybe for only 2 patients, where really there was a family history. We have a familial clinic once a month run by Dr. Said Othman. We refer those cases to him, and usually we have this prolonged family history, but we do.
I ask this question because there are some people, they would say that if the mutational burden is more than 30 to 40%, probably you need to check for germline, or you think about germline mutation in AML patient.
The burden, sorry, burden of what?
Mutational burden.
Of the FLT3?
Of the, no, for the, like the RANX1, GATA2, any other mutation with a high mutational burden, you think about germline rather than somatic mutation.
So I think we reached the hour. I would like to thank all the speakers, Dr. Marwan Shaheen, Dr. Salim Al-Data, and also I'd like to thank all the audience and the SSBMT for organizing this, and Stellas for sponsoring this activity. As you know, we have this SSBMT webinars on weekly basis almost now for close to 1 year. But because of we are approaching to the end of Ramadan and Eid, we will hold these activities for the next 2 weeks, and inshallah we will resume it after Eid, and there will be announcement at that time for the next speaker. At the end, thank you everyone.
شكرا.
Thank you.
يعطيكم العافية.